right, great. Well, thank you very much for inviting me to talk today. So as Camilla said, I'll be talking about how do we actually draw a causal graph. And so this talk is outlining the sort of start of a proposal that we've been working on for evidence-based best practices around drawing causal graphs. I'm going to focus on DAGs, directed acyclic graphs, but the sort of idea is that these principles would also apply to things like SWIGs with some modification for those other types of causal graphs. I also want to say that these are not finished best practices. We're definitely still working on identifying what areas need to be explored more and solutions for them. So I'm hoping at the end of the talk, we can have a little bit of a discussion about some of what I think are still open questions that need to be answered to really develop some good and helpful best practice guidelines. Okay, so just so we're all very much on the same page, when we're talking about causal graphs, I'm really just talking about this graphical tool that represents mathematical relationships between variables or factors in the world. And so since that's a graphical tool, we can draw them in fun cartoons, we can draw them with words, but either way, the rules that these graphical graphs follow actually tell us about what we believe to be the underlying mathematical relationships. And so, we've seen really an explosion of interest in using causal graphs in literature over the last, 2 decades. So this is from a nice review led by Peter Tennant, where, showing that really get this huge explosion of articles which say that they've used a causal graph, mostly DAGs, in their study. But when we look at those actual articles, many of the published causal graphs are either incomplete, so they maybe consider only one of the causal relationships of interest in the study, or they only include measured covariates and don't include any unmeasured covariates that might be important, but that they simply don't have data on. Or they might be inappropriately drawn. And so one of these is that, not aligned with time is not necessarily wrong, but it can make it very hard for the viewer or the reader to parse the graph. And so, that just limits how easily people can convey their assumptions with their graph. But another one that's really common to see is these sort of summary covariate categories. Sometimes we call these super covariates, where they simply present some category like socioeconomic status, and they don't go into detail about what is in that category and how the components of that category, the actual underlying variables that you might measure, are related to the rest of the variables on the graph. And then another thing that's very common is that we don't see any summary of the supporting evidence for the nodes and the arrows. It's really very common. People will just present the graph and not their process for building it or why they believe certain pieces are there. And especially, we very, very seldom see any supporting evidence discussed for the omission of arcs or nodes from the graph. And then finally, something Peter found when he looked at these is that a large number of these studies would simply say in the methods that they use DAGs to determine their covariates and then not include an image at all. And, as we just said, the whole point of a causal graph is that it's a graphical representation of our assumptions. So if you're not going to include a graph, then there's really, it's kind of like, why did you even bother with the DAG? And so kind of seeing that people weren't using causal graphs very well, we wanted to know why don't people use them and what things are limiting them. And so we did this survey of epidemiologists. This was back when EpiTwitter was a thing. So that was partly EpiTwitter and partly we also surveyed SER, Society for Epidemiology Research members in the US. And based on that survey, we found that 40% of the epidemiologists we surveyed had never used a causal graph, which actually was lower than we were expecting. So that was kind of nice to see. But of the 60% who said they had used a causal graph, only 20% reported using any kind of systematic process to create them. Everyone else was sort of saying, well, they just sort of, put what they thought belonged on there and moved ahead. And when we asked about, what were the barriers to use, the main thing that really came out of that was the lack of training tools as a major barrier. People felt that they didn't know where to start. And this also, I see this when I talk with people in person. Something that I'm commonly told is people will say, I don't know where to start with a causal graph because the first time I built one, my advisor told me go build a DAG, and I went and I did this deep dive and I came back with this huge DAG full of everything, and my advisor was like, there's too much on there. What is this? And then they felt that they didn't know how to build it, build a DAG. But hopefully, as we'll see today, actually, probably that first approach is much better than the approach that leads to a simplified DAG. Because what we see in the literature is that papers about causal graphs and how to use them, what they are, et cetera, tend to focus on these really simplified graphs and how to read the bias from them. But none of these are actually DAGs because none of these are going to capture everything. Well, they're DAGs and they're not causal graphs because they're not going to capture all the causal relationships we think of. They're really more just pieces of a causal graph and how to read those pieces. But a lot of people have seen these in the literature, and so these ones are taken from Greenland and Robbins 1999, which is sort of the first causal DAG paper for epi. And people have seen these, and so then they think, okay, a DAG should have 5 or 6 variables and only a few arrows. But that's really not what we need when we're trying to summarize the state of the world. And when we look for training materials that talk about creating graphs as opposed to just reading them or reading the biases off them, what we often find is that these take the form of checklists or tips. So this is an example from, a Agency for Healthcare Research and Quality document on how to develop a protocol for observational comparative effectiveness research. And in the chapter written by Sauer and Vanderweel, they have this checklist for DAG development. And if you look at the left-hand side of it, you'll see that the 2 items on the checklist are create a DAG and create a second DAG, which is maybe not the most useful for people who are trying to figure out how to create a DAG. And there are some considerations in the middle of this, but again, they don't really tell you, okay, what are you going to do? What is your first step? What is your next step? So that kind of establishes, I hope, the need for some consensus around how do we actually build causal graphs. And so in putting that together, there's 3 pieces that we've kind of focused on. The first is how to get started drawing a causal graph. So you have, your blank paper and your research question. Where do you start? The second piece is how to really systematically build out and then trim down the causal graph once you've got the sort of starting framework. And then the third piece, where if we want people to use causal graphs most effectively in their research, we need to make sure that they're presenting the graph and the graph building process in some kind of systematic way. So the third piece is around what should we do to present these graphs and the graph building process. And so for getting started drawing a causal graph, the very first step, which I always tell people to start with, is to identify what I call the core variables. And these are your exposure, maybe multiple or only one, your outcome, and any kind of restriction or selection variables that are important. So this could include competing events. It could include, nodes that you're restricting on. It could include loss to follow-up. But these are things that are built into the study. So not confounders that you're going to adjust for, but things where you're only collecting information from one set of people. and use these to build what we call a skeleton graph. And so here's an example from the Meteor trial, which is a trial of surgery versus physical therapy from knee osteoarthritis. And with this trial, the original follow-up time was 5 years, and then they wanted to do a 12-year follow-up study. And so they asked me to help with designing this, to think through various different causal problems that could have arisen between the original end of this trial and the new trial. And so in thinking about the core variables of this study, we have two different exposures. We have randomization, which is the exposure if we're doing an intention to treat analysis or effect estimation. Surgery, which is the exposure if we're doing a per protocol effect estimation. Then we have the main outcome of the trial, which was short-term pain up to five years. And so there were various different time points that this was measured at, and we can study it at different time points. But we sort of think of short-term pain as one piece. And then the trial ended, so everyone went their separate ways, right? And so then we had to bring people back in for the long-term study. So we have a long-term follow-up outcome, and we have a restriction variable, loss to follow-up during that period between the two trials. In fact, they actually were able to bring back almost everyone. And so in the end, this didn't really matter. But in thinking about what could matter, this is obviously a key piece. And so when we're thinking about the skeleton graphs, what we want to focus on is, so what are those core variables? When do they happen? How often do they happen? So do we need to be including them with multiple time points or just a single time point? In this Meteor trial, the treatment group was the surgery group. So surgery was a one-time thing, and then both groups got physical therapy. So we're really thinking of the exposure for the per protocol effect as surgery versus no surgery in the context of physical therapy. And then also things like who determines the core variables. So are these things that the investigator is saying we're only going to include people who have this set of variables, or randomization, for example, which is assigned by an investigator, and then where those are determined by the investigators, what values are permitted. And so you can use that to build your skeleton graph, and this is the one that's going to look the most close like those Greenland and Robbins DAGs, where we have just a few nodes and it's pretty simple. And this is going to help you think through the starting point of what you're doing. So the second step is to take a look at that graph and ask yourself if this actually depicts the question that you want to answer. When you look at that laid out like that, is it clear to you that you're actually trying to ask a causal question? And is the question that you're trying to ask answerable by even hypothetically changing the exposure variable in some way? If one or both of those are not true, then you probably do not need to continue making your causal graph. And so as an example of that, so there was a paper several years ago looking at frozen shoulder and cancer in, I believe it was a Danish registry. And in that paper, they had not adjusted for frozen shoulder. And there was a lot of discussion about whether that was inappropriate, because isn't frozen shoulder going to be a confounder for a relationship between cancer and frozen shoulder diagnosis? And so this is sort of the skeleton DAG there, where we have actual frozen shoulder, cancer, and frozen shoulder diagnoses. And frozen shoulder diagnoses could happen, before or after cancer. But I've organized them this way so that it's clear that frozen shoulder, if we had that information, could be a confounding variable. But when we look at that, we have to ask ourselves the question, are we really trying to know whether or not cancer causes frozen shoulder diagnoses? And if we are, then having a frozen shoulder is very much potential confounder, assuming that there's any relationship between frozen shoulder and cancer. And so we would want to think about controlling for it. But in fact, what the authors of this study were trying to do was to say, could we use frozen shoulder diagnoses as an early warning system for predicting cancer diagnoses? And in that case, since we actually don't think that cancer causes the frozen shoulder diagnoses, but we think that frozen shoulder and cancer might be somewhat related, we don't want to control for frozen shoulder because the goal here is actually to detect the association that comes through the confounding pathway, because we don't believe that there's any true relationship between cancer and frozen shoulder diagnoses. And so that's sort of an example of how, thinking through the skeleton DAG might help us figure out, well, what question are we actually answering and what should we do to answer it? And so then the third thing that we want to do with the skeleton graph is find the weak points. So, we want to kneecap our skeleton. And so what we mean about that is thinking about the structure of the skeleton graph you have. How might bias arise in a study involving that skeleton? So are there arrows where if you were to add them, they would create important bias pathways? Are there nodes that if you added them, they would create important bias pathways? And how could your restriction variables lead to bias? So as an example, back to the meteor study, we're not worried about confounders for randomization. And so I'm just looking here at the ITT, but so we're not really worried about confounding per se, but we are potentially worried about common causes of loss to follow-up and pain in the long-term follow-up trial. And so, because loss to follow-up is conditioned on, it has the potential to become a collider, and therefore we need to think about variables of the type U long-term follow-up here, where if long-term follow-up is not random, then we could get bias. And so now we know when we're moving ahead to build our full DAG, we really want to make sure we're paying attention to common causes of loss to follow-up and pain at the end of follow-up. And so this step is really just helping us make sure that when we go to build our DAG, we're focusing on most of our attention on the places where we're most likely to get bias if we ignore them. Okay, so the second piece of what we want to do is to build and then trim out a causal graph so that we get a graph that really represents all our assumptions about the world. And so here there's sort of 4 broad steps that we might take. The first is to identify all potentially relevant variables. The second is to determine which, if any, match those weak points we identified or make weak points that we didn't identify before. The third step is to take a step back and think about what is not on the graph and whether or not those things should be on there. And then the last step, try to find some evidence to support exclusion of things that are not on the graph. And as we'll see, this is probably the hardest of the whole part for various reasons. Okay, so one of the strategies that we found works best for the first step of identifying all the potentially relevant variables is what we call a systematic scoping review. And so here we're using a systematic search strategy, so building out a search hedge, and then not using a systematic review strategy for the papers. So once we've pulled all of the papers that show up on our search hedge, we're going to do a focused assessment of those papers. So we prioritize meta-analyses and literature reviews, and we prioritize more recent work under the assumption that these are going to give us the sort of most consensus-based and most up-to-date information on potential relationships. One thing that's important to note at this point is that we're not going to do any kind of quality review yet, because when we're just looking for potentially relevant studies, we don't actually care if these studies are correct. We just want to know what are the things that people have thought might belong on this causal graph because people think they might be related, right? So we're going for maximum possible variables. And so because of that, we want to make sure that we're extracting relevant covariates in either the methods or the results. And then at some point when you're doing this, you'll get to a situation where as you work down your list of studies, you're not getting any new information. And so at that point, you don't need to keep reading. And so this is why we call it a systematic scoping review, because the search strategy is systematic, but the paper review and the extraction is really only going to be for a segment of those studies. Sorry, my computer keeps clicking forward fast. Okay, so here's an example of a search hedge that we did. This is for the Meteor study again. And so we have this stem for the search where we have the outcome, variables of interest, knee pain, loss to follow-up. We also have the sort of population that we're studying, knee osteoarthritis and meniscal tear. TKR is total knee replacement or total knee arthroplasty. This was something that after creating the initial skeleton DAG, we realized this could be a potential second sort of restriction variable because it's a potential competing risk. If you have your knee completely replaced, then it's not clear what pain in that knee would mean after, because the knee is no longer there. So when we're thinking about long-term pain, no longer having that knee is an important potential competing event. And then we had covariate terms where we're looking for things that will help us identify potential covariates. So risk factors or confounders, activities of daily living. And these are sort of all the general types of things that we think might pull up studies that have looked at this question. And so, I think that there's more work we can do to identify what are some good search hedge terms to help us pull out studies that might have covariates of interest for sort of generally applicable across topics, but something like this where we're really looking for a broad spectrum of articles. Okay, and then once we've done the systematic scoping review, the next thing we want to do is to consult with the experts to make sure that we haven't missed anything important. And this is something that every time that we've done it, we found something that wasn't in our scoping review. So it's been really valuable. And so this could take the form of focus groups, surveys, or interviews with experts. And we're looking for key variables that we did not find in our scoping review that should be there. And so, depending on the types of thing we're looking at, patients and patient advocates also might be really important experts. For example, if we were looking for confounders of adherence to surgery versus no surgery, we almost certainly want to be talking to patients about why they're making a decision to get or not get a surgery that they were randomized to get, rather than relying on the clinicians for their interpretation of what those patients had been thinking. And here again, we want to try to use a systematic qualitative approach for soliciting and summarizing expert feedback. And the types of variables that we found kind of come up in this process are two categories. And these are what, in our experience, the literature lacks papers on variables that are obviously related, but not sort of thought of as scientific. So what does that mean? So in the Meteor study, an example is the number of stairs in the home, or related constructs like, is your bedroom or your bathroom upstairs? And this is not something that we have seen in the data. And after we found it in our focus group, we did a deep review and we could not find it in this knee osteoarthritis data. But when we talked to the clinicians, it emerged that if you have a total knee replacement, you can't use stairs for at least a month post-surgery. we also know that frequently using stairs can exacerbate knee pain. So when we're thinking about potential of total knee replacement as a competing event for later pain, right? We were thinking about, well, what are some possible things that might lead a patient to decide to have or not have total knee replacement, and what is something that might cause them to have more or less pain. And having a lot of stairs in your home, for instance, I'm on a fourth floor walk up, right? I have to use a lot of stairs. So if I had knee osteoarthritis, that might exacerbate my pain. But it also might mean that I'm unlikely to have a total knee replacement, because then I would be trapped in my apartment for a month after the surgery, unable to go down. There's no elevator, there's no other way down except 4 flights of stairs. And so number of stairs in the home is clearly going to be a confounder of some type for pain and total knee replacement, but it's not in the data. This is something that was very obvious to the clinicians once we started discussing it, but nobody collects it. The second type of variable that is not in the literature are variables that everyone knows are not related. And so this is partly due to publication bias and partly just due to the fact that people don't study things that they don't think are important or related. But this is a big challenge for us, because to confidently remove nodes or arrows from our graphs, we really ideally need robust null results. But even when studies are done on things that are probably not related, when they're robustly null, it's very hard to get them published. So this is another reason why talking to subject matter experts in the field, to kind of have them think about, like, the sort of file drawer papers where, oh yeah, we studied that, but it was not related. That kind of information can be really useful, and you can get that from focus groups or surveys or interviews, that you can't really get that from a literature search as easily. Just want to sort of go a little briefly over what our process was in the Meteor study for this. So we had our draft graphs from the literature review. We had focus groups with clinical and research experts. And then after that, after 2 focus groups, we synthesized our results into this table of potential edges. So 2 variables and the potential link between them, and gave the experts a survey with saying, here's the literature that supports this edge, if there is literature, and then do they agree that it belongs there or not, as well as some of the edges, or sort of the key edges that had been removed in the focus group. And then we asked them to either agree or disagree with this information. And so then you can see here, we had pre-specified that 50%, if at least 50% of the experts agreed with an edge, then we would put it on our DAG. And so you can see here, we had somewhere everybody agreed that a variable was important. And so here we actually sorted it by the end of the node. So these are variables that are known or suspected to be caused by pain. And then, so, everyone agreed that pain could reduce exercise, whereas there was less clear agreement on whether or not pain might lead to kidney disease. And this probably makes sense that there was less agreement, because this is one where it was the sort of more indirect relationship, pain leading to increased NSAID use, and then that leading to potentially to kidney disease. And so having this kind of summary helps them provide us with some ability to kind of think through whether there are arrows that we feel very sure about or not that sure about at all. And in fact, none of our arrows had less than 50%. So we didn't end up removing any like this, but we could have. Okay, and so the lessons that we learned there, one of the things we found really difficult to convey to our clinical experts was this concept of causal consequences. And so you saw there, we were asking about things that were caused by pain, And this was really important for this long-term follow-up study because we were thinking about pain in the initial study leading to potentially other procedures or loss to follow-up. And so we really needed to know, what was happening downstream of the short-term pain in our study, but we found it really difficult to convey that idea of a causal consequence to our clinical experts. And so that's something where we need a little bit better understanding of how to convey that. We also just wanted to know, yes or no, do you think that these things might be related? Because we're looking for everything that could be potentially important. And the experts found it really hard to ignore the issue of strength of relationships. They were constantly asking us to put in what is the estimated strength of this relationship into our tables and into our surveys. And we're like, it doesn't matter. We just want to know yes or no. But that was something that it was the next time we'll need to do some more training about. The idea that omitted edges were the stronger assumption was totally new to most of our experts and really harder for them to think about. And so, we tried to ask for extra support for those, but, as we discussed, these tend to be things where there's very much less information anyway, and you're asking people to think about things that they're not seeing. And so that is definitely a lot harder. And then, the last thing that the experts and also the reviewers kept asking for was quality review of the studies. They were like, but, and it was like, it doesn't matter. We're just looking for what do people think might be related so that we can then potentially include them. And it's the studies, the few that we found that showed us, or that said that there were no relationship, those were the ones where we were doing quality to review because those are the ones that are the stronger assumption. So, one of the sort of key open questions from this first process of building out and trimming your graph is this idea of when is enough enough. And so if you're familiar at all with the causal graphs, the sort of party line is, well, it needs to include all variables that are common causes of any two other variables already on the graph. But in theory, you could do that to infinity. So we need some way of deciding when we stop building out our graph and how to prioritize looking for potential variables and lengths. And so this is another question that we tried to evaluate with a case study. So this case study, we looked at the Coronary Drug Project, which is a randomized trial from the 60s and 70s, looking at a variety of cholesterol-reducing medications and heart disease in men. But we focused specifically on the placebo arm of this trial, which was a nice big, it's like almost 3,000 people, and we have as the outcome mortality over 5 years. And this is somewhere where, we very much do not think adhering to placebo would be an actual cause of mortality. So any relationship is expected to be due to bias in the study and the analysis rather than a real relationship. And so it makes it a nice case study for assessing different graph building approaches. And so in this study, we looked at 3 different approaches to building out the graph. So the first approach was what we call the outcome-driven approach, where we looked for all known and suspected outcome causes. And so here we're looking, some of them you'll see here, we ended up not having occupation and education level in that graph, and that's because of the trial design and how sort of narrow those categories were in the trial rather than the fact that these things, they're obviously have associations with mortality. The second approach that we tried, we call it a trimmed approach. So we took that outcome-driven approach and then we limited it to the subset of variables that also were known or suspected to cause exposure. So here, exposure, again, is medication adherence. And then the final approach was what we call the maximal approach, where we thought, well, we don't we're not necessarily confident about whether arrows should be omitted between a variable and exposure or a variable and outcome. So what if we put on everything that's suspected to be an outcome or an exposure cause? And that way we're making the fewest assumptions about omitted arrows. And so, basically what we found when we did that, you can see here, we've got the 3 types of DAGs. The baseline adjusted analyses is just adjusting for baseline covariates that were identified. And we can see that it essentially doesn't really matter. For reference, the unadjusted estimate here is an 11 percentage point difference in 5-year mortality, which is, obviously more than taking a placebo pill could do anything about. But when we just adjust for baseline covariates, it doesn't super matter which variables we choose. On the other hand, when we adjust for both baseline and time varying adherence covariates, so these are basically mostly the time varying values of the baseline covariates where they exist, and we use IPW, what we see is that it did matter quite a lot. And so we get sort of compatible with null results from the outcome-driven and the trim DAG, but not from the maximal DAG. And so the sort of bottom line of this case study was that, theory tells us that outcome causes have more potential to cause or have the potential to cause more bias. And we did find that focusing on things that are known or suspected outcome causes gave us the best confounding control in this study. But an important caveat here is that this is a study where we very much believe that there is no true effect. And so none of these outcome causes could possibly be a mediator because there's nothing to mediate. And so when we're thinking about whether a situation where the true effect is non-null, we might need to retest that. But that's a lot harder to test because we don't have a true value of the effect to compare the results to. And then, the sort of other key point from this is that making a good graph is only half the battle. So on the left here, you can see this is the IPW adjusted results, and it makes quite a difference. These are p-value curves. It made quite a difference which type of graph we used, but on the right, you can see overall the risk difference is much bigger, and it really didn't make that much difference how we chose it. So if you're gonna spend a lot of time doing a good graph, you want to also make sure you're doing good analysis. Okay, and then the third thing I wanted to just talk on briefly, and then it would be great to have some discussion, is the idea of finalizing a graph and presenting it. So once you've kind of got this big graph, you really want to make sure, again, you kind of do a deep search on any omitted edges or nodes that came up and quality assessment on any null results you can find, which I can tell you will be very few studies. And then you have a graph now, you want to think about the potential biases that are in that graph if you don't adjust, but do condition on the restriction variables or the selection variables or competing events. And then think about which nodes can be used to close those pathways and check that using those nodes to close the pathways doesn't open any new bias pathways. And then finally, you can trim your graph by removing variables which don't cause bias and are not needed for preventing bias, because those are not going to be really necessary for what you're doing. And so then, but then when we present a graph, we've got sort of various stages here. And so really, you're going to want to really convey what you've done, you really want to present multiple formats and versions. And for each one, think about, what information are you trying to convey? And also, what information do you wish you had access to when you were trying to build your graph? Because if we can include that information, it'll make the next person's graph building easier and hopefully make the whole system work better. And then, I think you almost never see people describe how they built their graph other than, we use literature review, but no details. So don't forget to describe really the full process. So one of the things that I typically will include a sort of a final skeleton graph, and this is sort of taking the final graph and boiling it back down to the skeleton. So here you can see, we thought, okay, in the end, actually now this skeleton, there are important confounders that we needed to add to it because there are important confounders of adherence and this is not from the Meteor study. Sorry, that's the wrong label. But they're important. It's from a similar study. They're important confounders of adherence and death. So we add those to the skeleton graph. Measurement also turned out to be an important consideration here. And so that's being added to the skeleton graph. And then you can see we've highlighted the paths that lead from randomization to death. Are then highlighted in red so that people can kind of see the effect of interest and compare the bias pathways. And then this is probably unreadable, but just an example of like a full graph that we created through one of these processes. Just to remind you that we're really not making skeleton graphs, we're making causal graphs that have a lot of things going on. And so when you get your graph, this is one of the reasons why it's very helpful to arrange things in time from, the past to the future so that you can actually parse this, because if these weren't arranged in nice columns, it would be much, much harder to figure out what was going on here. And then the last thing that we found is useful is these supercovariates can be useful, but if you're going to make a supercovariate like current health status, you should also present some kind of summary, either text-based tables or graphical, that shows the relationship between the various different pieces within that super covariate. So this is for the coronary drug project study. And here we had, on the skeleton graph, we say, okay, well, current health is a variable that might predict adherence, at baseline. And what does that actually mean? Here's the sort of mess of covariate links that we think goes into current health. And then a final thing is sort of tables summarizing some of the key points that we want to make sure people really see. So what are the omitted arrows? This I find is usually easiest to present in a table because there's nothing to show in a picture, but you can say, okay, these parent nodes to these child nodes, these are arrows that we have not included. And it is also useful to provide some rationale for those removals. So a table is a nice way of doing that too, where you can say, okay, this one, for example, is saying, well, we didn't have systolic blood pressure. This is for the TRIM DAG on the coronary drug project. We ended up removing it because even though it's predictive of death, we didn't find any evidence that it would be predictive of drug adherence, especially for placebo, because it's not something that was, commonly measured or, that the patients would really know about in the 60s, 70s. And it was not something that they could sort of detect for themselves. It didn't have symptoms. We didn't think that, and we didn't find any literature to support it. So we had some search results that had sort of provided some evidence for that, but mostly this was sort of a summary of expert discussions. And then this is not really DAG specific, but for any study, in order to help facilitate DAGs, it's really useful if you give details on how the covariates are operationalized, because that's going to be really useful for people like me who are trying to build DAGs off the evidence. So that's just a plug to talk about your operationalization. Okay, so just to finish up, that seems like a lot of work. Can you automate it? The good news is there are theoretically methods to do this. So there are causal learning methods that use machine learning. But the bad news is they probably won't help. This is an example where this is for the coronary drug project study again. The dashed black line is the outcome-driven, so the best performing of the DAGs from the experts, and then the ones in color are all various different covariate sets spit out by the causal learning processes of various different types. And you can see that, if you were doing this for something where there's a true effect, it could be very difficult to know which of those to choose. So it probably won't help you. And then this one is very hot off the presses, is coming out soon in Journal of Causal Inference. So we also asked whether LLMs could help you identify your confounders. And they're pretty good at saying, yes, this is a confounder, but only because they say yes, this is a confounder to absolutely everything you ask of them, including things that are completely, totally not confounders, like subject ID number. So they're not going to help you either. All right, so just to summarize, in terms of getting started, identify your core variables, confirm the question, and search for weak points. Then build and trim your graph by using a systematic search process. Focus on known and potential outcome causes is potentially a useful way, but that, caveat, if you think you have an actual effect, you need to think about what of those might be mediators, and then make sure to involve experts. And then finish up by, presenting really ideally more than one graph so that you can highlight the key features and provide supporting evidence. Okay, so I'm going to finish there. I know we don't have a huge amount of time for questions, but I tried to think about some of the open questions, which I think still need case studies or other work to answer them in terms of the best practices. So first of all, what do we do? How do these things change if the true effect is non-null? How much do covariate links really matter, and how detailed do we need to be about them? And do we need to be conducting a systematic scoping review for every pair of covariates? If so, this is going to get out of hand really quickly. Third thing is, how much do we need to make sure that the subject matter experts know about causal graphs in order for them to provide input? Is it enough to just ask them sort of questions about variables, or should we be teaching them about causal graphs first? And in terms of getting feedback from them, is it better to use graphical, tabular, text-based approaches, and for which types of experts? And then lastly, how do we help people and ourselves to think about those things that are not on our graph but should be, which I think is a very difficult thing for everyone to think about. You have to think about what's not there. Okay, so that's everything that I have today, and hopefully we can have some discussion. Thank you.